Okay.
Oh, I see. We have a couple people. So we'll get started in about 5 minutes. We're just going to give people a few minutes to come in.
That's okay. Are you going to share your screen with the other info?
Yes. Okay. Oh, good. I see more people are joining now. We'll get started in a couple minutes. Just in the meantime, if you want to make sure that your sound is working and that you can see the title screen, the title slide on your screen, that would be good. And if you do have any issues, just drop a note in the chat, and either me or Olivia will help you out with that. Awesome. I see a few more people are joining us. We can give it maybe a couple minutes just to give everyone time to join, and then we can get started after that. In the meantime, you guys can drop in the chat where you're from, what organization you're from, and maybe what topics you'd like to see in future webinars. And I see someone has a question. Um, sorry, I'm just trying to figure out how to unmute you. Olivia, would you mind helping me out with that for a second? There it is.
Uh, Ethan, if you have a question or if you had any issues, you can go ahead and unmute now.
Okay,
Maybe
I
that
might.
was an accident, so if there's any questions or issues, you can go ahead and put that in the chat. We can go ahead and get started. Thank you.
Awesome. Sounds good. I'm going to do that, and we can get started. Awesome. So, good afternoon, everyone. Welcome to the Professional Development Webinar Series, Strengthening Education and Communication in Vector-borne Diseases. This is hosted by the VectorED Network, which is a CDC-funded vector-borne disease training and evaluation center. My name is Indira Chakrabarty. I'm the VectorED Network Evaluation Specialist. And I'm also with Penn State, and I will be moderating the webinar today. Also with me is Olivia I'm so sorry, Banyani. And we're both from the VectorED Network. If you'd like to know more about our other programs, evaluations, and trainings that we have going on or upcoming, you can visit our website, which Olivia just dropped in the chat. So a little bit about this series. This series was developed to support professionals like those in extension, public health, education, related fields who work to translate science into practice. So we recognize that while many of us have deep subject matter expertise in vectors and vector-borne diseases, we don't always have the opportunity to strengthen the communication, design, and evaluation skills that help our work make the biggest impact. So
Indira,
each
you have
month,
a comment. Not seeing
oh,
anything in
let's
the
see.
chat.
Oh, Joellen cannot see anything in the chat.
Thank you, Joellen. I think you should be able to now. Thank you.
Yay, okay, good. Yeah, so each month, this professional development series will highlight a topic that builds on those applied skills. We try to have sessions be practical, resource heavy, and interactive wherever possible, with examples drawn from vector and vector-borne disease context to keep things relevant and real world. So if you want to keep in touch with us for future events, we invite you to connect with us on LinkedIn or to sign up for our newsletter, which I think Olivia is also about to drop in the chat. Thank you, Olivia. So please note that this session will be recorded. You will also receive a link to the recording following the presentation, and the webinar will also be posted on YouTube and our website with the additional resources linked so that you can extend your learning. I believe we are recording, so I will proceed. I have a few housekeeping items if you're new to webinars. So this session will run for about 60 minutes total, with roughly 45 minutes for the presentation and time at the end for discussion and questions and answers. All participants are muted to reduce background noise, and if you experience any audio issues, check your settings now using the arrow next to the microphone icon. You're welcome to post comments or reflections in the chat at any time. But if you have a question specifically for the speaker, please use the Q&A feature to make sure it doesn't get lost in the chat. Let's see. Live captions are also available. To turn those on, click the CC button on your toolbar. And if you need to step away or leave before we wrap up, you can click the leave button in the lower corner of your screen and it won't interrupt anything in the webinar. But we encourage you to participate, respond to prompts, share examples, and use the chat to connect with everyone. The series is supposed to be interactive and practical, so your input is definitely always welcome. So I want to introduce today's speaker for today's webinar. We are very lucky to have Dr. Peter Winch, who is a professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. He's highly engaged in efforts to respond to climate change at Johns Hopkins University and has served as co-chair of university-wide Sustainability Leadership Council since 2019. The main focus of his research is community engagement in health, behavior change interventions, and qualitative informative research for environmental health, maternal and child health, and infectious diseases. Today, Peter will be sharing some information about health-related behavior change in the context of vector-borne disease. So now I would love if, Peter, you could share your slides. So I'm going to stop sharing for a second. And Peter, you are welcome to share your slides.
Okay, so can you see full screen, Indira?
Yes.
Okay, I'm going to start. As one prepares a presentation like this, you realize how much else I could say. I mean, this could be a course. And also, there's so many different vector-borne diseases, and here are some of them. And I mean, ideally, I would drill down and get very specific about each disease and how you need to modify behavior change. Approaches to be for the specific mode of transmission and place of transmission. But I can't do that. I'm going to talk more about Lyme disease than anything else, just because there are the most materials out there and most activity in behavior change communication for Lyme disease. And of course, there's concern that all of these diseases are increasing due to changes in land use and climate change. And here, just for Lyme disease, you can see each dot represents a case. So there's a lot of cases, and in fact, so many that we can't even count them. And it seems to be increasing, but we're never sure because definitions of the disease change. Every time there's a change, it seems to go up. But then we're wondering, is it really going up, or is it the definition? But if we make the assumption that it is going up, one question we ask ourselves is, are we doing enough, or could we be doing more to promote behavior change to protect people from Lyme disease and other vector-borne diseases? So in this presentation, I'm going to talk about what is a health behavior. I'll make a few comments about the preventive health behaviors for Lyme disease because I'll be using them as examples later. I'll talk about the model we use here in our program for constructing interventions to change health behaviors. And then I'll be talking about 5 factors that affect preventive behaviors for vector-borne diseases and what we can do to change them. So, what is a health behavior? It's pretty broad. It's any action that an individual engages in that affects their health either positively or negatively. We need to define behaviors in a way that's specific, modifiable, and measurable. Otherwise, if we don't know what we're trying to change, we can't change it. So, specificity, we need to be clear what needs to be done, by whom, how, and when. And with vector-borne diseases, the specificity is especially important because what needs to be done, where, by whom, it's going to vary by the disease and the vector. Then it needs to be feasible to practice the behavior. And finally, there needs to be some way of measuring the behavior, because otherwise we won't be able to know, are we achieving anything or not. So on the left are what I would say are not good examples. When I say not good, it's not because it's not important. When I say not good, it means it's not specific enough that people know exactly what we want them to do. So if you say practice good oral hygiene, well, what do we mean by good oral hygiene? So on the right is the kind of specificity we want to get in. Brush your teeth twice a day, soft bristle brush, replace your toothbrush every 3 or 4 months. I know as soon as I show you this, people say, oh my God, I haven't changed my toothbrush in 6 months. That's okay. We're not going to get on your case. And use an American Dental Association accepted fluoride toothpaste. Or exercise regularly. Well, we got to say what is exercise and what is regularly. So more detailed and specific would be perform at least 150 minutes of moderate aerobic activity or 75 minutes of vigorous aerobic activity every week. And you can get into more detail on that. So that's specificity. Modifiable is also important. Of course, the best if we really want to get rid of vector-borne diseases, we'd say don't go outside your house ever, but that isn't feasible, so that isn't our recommendation. So on the left are what I would say are not good examples. And I'm saying they're not good examples not because they're not important, but because they aren't really feasible. For example, do not let anyone smoke in your house ever. Well, what if somebody who lives in the house smokes? Or what if people come over who smoke? So more feasible would be meet with members of your household, designate 1 or 2 rooms as non-smoking zone in your home, and remove ashtrays from these rooms. And in that way, you're creating a part of the house that's free of smoke. And we find that when we do that, the smokers gradually smoke less because it's a bit of a pain to go from the smoking part of the house to the non-smoking part of the house. And they start feeling, well, it's actually easier to just not smoke. Do not drink soda ever. That's not feasible. There is concern that a lot of people are drinking too much soda. So more feasible would be switch to sugar-free or diet soda as much as possible. Or limit soda drinking to mealtime or special events. Do not drink soda between meals. And drink water as much as possible. Between meals, only drink water. So that's more feasible what we have on. And then do not inject drugs ever. Of course, if you aren't a drug injector, that might sound feasible. But if you are an active injector, that's too great a jump. So more feasible might be always use a clean needle while injecting drugs. Don't share needles with others. Get a fresh supply of needles from a needle exchange van when it passes by. So now, switching from those general examples to Lyme disease as an example. CDC has behavioral recommendations in 4 different categories, and each category could be an entire presentation. For example, prevent ticks on pets. That could be an entire presentation. I'm of these 4 categories, I'm going to talk about prevent tick bites when outdoors, and here I'm referring to humans. And these are the recommendations that CDC has. Avoid grassy, brushy, or wooded areas where ticks live, which doesn't mean you don't go outside, but maybe you don't poke around in a pile of logs. You don't walk straight into the bushes. Use EPA-registered insect repellent containing DEET, bacardin, and there's a number of others. Wear long-sleeve shirts and pants or clothing and gear pre-treated with 0.5% permethrin. Check your body, clothing, and gear and pets for ticks during and after being outdoors, including even in your own backyard. And remove attached ticks as soon as possible. Do not wait to go to a health care provider. Like I say, I can see you in 3 days. No, you don't wait 3 days to remove the tick. You remove it right away. So if you look at those, that's really quite complex. And how do we encourage people to do all this stuff? And one thing I like about the CDC website is that it has photos, and it's a lot easier for people to remember photos like this than to remember a whole list. So when I look at a list of behaviors like this, we have a model that we use, and here's our model. In the middle is a health behavior, and I just showed you a list of 6 or 7 health behaviors. We look at them one at a time, and we think, what are the factors that affect whether a person practices that behavior or not? So that's looking left. On the right, we're thinking, what's going to be the result to that behavior? What conditions for public health impact will it produce? And then what will be the public health impact? So with any health behavior, we analyze the factors, and then we think, what interventions can we put in place to affect those factors? And if I were to apply this to permethrin, permethrin, by the way, is a great technology, and it's surprising that a lot of people have never heard of it. And a great thing about permethrin is, say you treat your hat or your socks or something with permethrin, the permethrin stays. You can go out the next day and you don't have to retreat it. Of course, if you wash it, you're going to have to pre-treat it, but permethrin is long-lasting. So what are some factors that affect permethrin application at parks and trails? Well, one factor could be feasibility, and it's only going to be feasible if permethrin is there. A second factor is a behavioral cue or reminder. For example, the alarm clock going off in the morning, that's a reminder. And then descriptive social norms, that is your perception of what others are doing. So we have these 3 factors. What can we do about feasibility? We get a permethrin for sale at the entrance of a park or near a trailhead. What can we do about behavioral cues? Right at the start of a trail, we get a bench, and with a big sign, this is your bench for where you can apply your permethrin. And what can we do about social norms? Well, one part of promoting social norms is to use this word we all the time, or talk about people. We are all doing this. Everybody's doing this. And social norms are very influential. I'm going to be coming back to social norms. So that's an overview of application of this general behavioral model to a behavior, in this case, pre-treating your clothing with permethrin. So now, for the rest of this presentation, I'm going to be talking about what I think of as the big 5 factors affecting preventive behaviors for vector-borne disease prevention. And here they are: social norms, self-efficacy, cues to action, understandings of vector abundance, biting, and disease transmission, and perceived susceptibility and severity of vector-borne disease. And this might be the most important slide I have in this presentation. So the first 3, I call the big 3, and the reason I'm calling the big 3 is that we have the most evidence in the literature that these 3 change behavior. In fact, we have a ton of evidence in the literature that these 3 change behavior. And these are all close to the behaviors. Like, when you're talking about social norms, you're talking about the social norms for a behavior. When you're talking about self-efficacy, you're talking about self-efficacy or confidence through practice of behavior. Cues to action are the cues to practice a specific behavior. Number 4 and 5, understanding of vector abundance, biting, and disease transmission, and perceived susceptibility and severity of vector-borne disease. Those are distal or far from the behaviors. And when I say they're far, if you understand vector abundance, that's great, but then you have to think what behaviors are associated with vector abundance and when do I need to do it? Like, there's a couple of steps to go from understanding of the vectors to the behaviors. There's a couple of steps to go in your head from understanding what the disease is to the behaviors. Whereas 1, 2, and 3, social norms, self-efficacy, cues to action, they're all directly related to behaviors. And the literature says that you can talk to people a lot about 4 and 5 and not get much behavior change. But if you work systematically on the first 3, you do get behavior change. That's what we see in the literature. So I'm going to start with social norms. It's one of the essential drivers of human behavior. And although we as humans, as a species, we have a high opinion of ourselves, really we're a bit like sheep in that if we see others doing something, we do it. And if we see others not doing something, we don't do it. And we never want to be the only one doing something, even if we know it's a great thing. If we're the only one doing it, we don't want to do it. And one of the theories about social norms is the focus theory of normative conduct. And Kellgren et al. Found that maybe the biggest determinant of littering behavior is how much litter people saw around. If people see a lot of litter on the ground in a place, they think, well, everybody's littering. And so if everybody's littering, I'm going to litter too. On the other hand, if people don't see any litter on the ground in a place, people think, well, nobody's littering and I'm not going to litter either. So litter on the ground isn't just unpleasant, but it's also, it talks to people, tells people that others are littering when they see litter. And here's what the focus theory of normative conduct looks like as a diagram. We have social norms, which are descriptive norms and injunctive norms. More about what those are in the next slide. And we have a normative focus. People apply norms to specific times and places. For example, it might be normal to litter when you're, say, on the street outside a convenience store. It might be normal to litter there, but it might not be normal to litter, say, in the living room of somebody's house. That might seem. So the normative focus is where and when are we talking about? So descriptive norms are what is the normal or typical or usual thing to do. And it's more directly related to a behavioral decision. Injunctive norms are what we think other people want us to do. And they're a bit less directly related to behavioral decisions. So if we talk about teenagers for a minute as an example, the descriptive norms might be what are other peers, what are other teenagers doing, and the injunctive norms might be, well, what do my parents and my teachers and others want me to do? And you can imagine the descriptive norms are often much more influential. Now I'm going to jump over to this slide for a minute. We often show people slide information about seasonality of vector-borne diseases. I'm going to come back to this in a minute. And we show people slides of seasonality, or information on seasonality, because we're saying, well, this is when they're biting. But if we add the magic word we or they, it makes it much more effective for behavior change. If we show people this graph, but without this statement, it's much less effective. So the statement here is, now in the spring, we all apply permethrin to our clothing and gear to prevent the peak of Lyme disease cases in June and July. And that we is a magic word. If people think everybody's doing it, again, we behave a bit like sheep. If we think everybody else is doing it, we'll do it. And if we think nobody else is doing it, we won't do it. Now in the spring is a normative focus, right? I was talking about how norms have to be salient in a specific context. So here for the vector-borne diseases, a specific context is in the spring, outdoors, in a park, or in the backyard. And the we all is communicating the descriptive norm. To amplify the message, you would show a group of people practicing the behavior. It would be great if you get a photograph of several people applying permethrin to their clothing. And if you're using social media to communicate with people, you might say, tell a friend that now is the time to do X and Y. Tell a friend that all of us right now are doing X and Y. So that was social norms. And I'm going to go on to self-efficacy. Self-efficacy is a statement of a person's efficacy expectations for a behavior. That's a bit of a mouthful, and what does it mean? In colloquial English, it means, do you think you can pull it off? And when I say I think I can pull it off, I'm not talking about Band-Aids. Okay, I can pull off the Band-Aid. It means the behavior, can I make that behavior happen? Can I carry through with it? Can I do it? So it's somebody's perceived capability or belief that they can successfully complete a given task. And we define self-efficacy in relation to specific behaviors. Now, I'm going to give you a bunch of weird terms, but then I'm going to apply it to parallel parking, and then it might make sense. But right now, looking at this slide, you're going to say, what's this guy talking about? So performance accomplishments mean you try out the behavior, and then you're successful in doing it, and you feel good that you've been able to do it. You feel good that you've been able to pull it off, and that gives you confidence to do it again in the future. Vicarious experience means your experience of watching other people do it. And if you see others do it, you think, well, maybe I can do it too. Verbal persuasion is when others encourage you to do it. And emotional arousal is, your nerves, your nervousness when you're trying to do it. And conversely, people telling you, take a deep breath, relax, you can do it. So let's apply this to parallel parking, and here we have somebody parallel parking. So there's a lot of steps in the process of parallel parking. To measure self-efficacy for parallel parking, we need to ask a person's confidence to carry out each of the steps, and then look at their overall confidence. So, applying the 4 sources of efficacy expectations to parallel parking, performance accomplishment would be having the experience of successfully parallel parking a car. Like if you know you've been able to do it in the past, that gives you confidence to do it in the future. Vicarious experience would be watching a friend or driving instructor do it. Verbal persuasion might be feedback and encouragement from a friend or a driving instructor. And emotional arousal, that could be the nervousness when the driver of a large truck is honking behind you, and that can lead to loss of confidence in your ability to do it, and it decreases your self-efficacy. And I'm in Baltimore today, and I see a lot of people never trying to parallel park in Baltimore because there's always a truck or a delivery van behind them honking, and that decreases their self-efficacy. Usually the way we promote behavior is we give people all the information and then just tell them to do it. But if we act on this idea of self-efficacy, then we need to create a conducive environment for people to learn the behavior, give people opportunity to learn from experience of others, provide modeling and feedback to build the self-efficacy and overcome challenges to adopting the behavior. Self-efficacy is totally focused on the behavior, how to do it. Modeling of the behavior, step-by-step instructions, how to do it better, encouragement to do it. We can promote self-efficacy in person or with groups through demonstrations, have people try behavior and receive feedback, role-playing of behaviors, and sharing of experiences with practicing behaviors. Although in person might be more effective, we can't reach everybody in person. So mass media, which of course, and social media, which we all complain about, can actually be really effective in promoting self-efficacy. So step-by-step demonstrations. So on social media, I have a video clip showing somebody applying permethrin to their clothing, showing somebody doing a tick check, showing somebody applying repellent. Testimonials or first-person accounts of people and their experience practicing behaviors, and tips for practicing the behaviors and overcoming challenges or barriers. Tick checks are an important behavior where I would argue self-efficacy is very important. Tick checks are hard to do. You need to know when and where to perform the tick check. You need to know where to look. You need to know what to look for. And then once you find the tick, you need to know how to remove it. It's difficult to do in-person demonstrations because of the intimate nature of full body examination. So one way to try to improve self-efficacy to do this is videos or YouTube clips that people would access through QR codes that show people how to do it and tips for doing it. Or testimonials with encouragement from regular checkers, like somebody saying, I check all the time and this is how I do it. If you're talking about a school population, you could have demonstration in schools. And tick checks are difficult because if ticks were this big, it would be quite an easy thing, right? There's a tick, get rid of it. It looks like it's the size of your hand, but of course, ticks aren't like that. Here we see an adult tick on the left and a nymphal tick, the ones that most commonly transmit Lyme disease, on the right. And it's really pretty small. And that's what people are looking for. So this is what makes building self-efficacy to practice tick checks difficult. People don't know what to look for. So you need to demonstrate to them how to do it and give them feedback if possible. So that's the second of the big three. And the third of the big three I'm going to talk about is cues to action or behavioral antecedents. Behavioral antecedent means what happens immediately before the behavior. These are triggers to practice behaviors. Examples are like the alarm clock is a cue to action to wake up in the morning. Reminders on physical calendars, reminders on email calendars. And cues to action are extremely important for vector-borne diseases because they're focal in transmission. And by focal, I mean you'll have a lot of transmission in one place and you move a little away from that place and there may be no transmission at all. So how do people know what to practice and where to practice? Well, you need to put in place cues to action. So here are some examples of cues to action or behavioral antecedents. For example, you have a roadside. You're now entering an area of the high transmission of a certain disease. The challenge with road signs is to make them seasonal, because if you have a sign, danger, there's a lot of ticks, and people are driving in Pennsylvania or Ohio in February, they're going to say, well, that's a stupid sign. And they start ignoring it because they realize it's not providing timely information. So leaving signs up all year might make them irrelevant, but can you have road signs up part of the year? Well, that's going to be a challenge. Maybe you need to cover it part of the year. maybe you could have labels on mapping apps or signs in parks and trails. So here's an example of a sign in a conservation area in Ontario. Um, at the entrance of the conservation area, it says high tick density, and it's got a scary looking tick. So that's a behavioral cue telling the person now is the time to practice the behaviors. Now, I think a sign like this isn't enough. Following the sign, you just say, okay, high tick density, and this is what you need to do. Permethrin on clothing, repellent on your skin. Do a tick check after leaving. I like this. I think this is really good because it's very specific about what to do. And you can see when and where you do it, right? You do it in your garden, and especially if your garden is close to the forest edge. And what do you do? 20 seconds applying an EPA registered insect repellent. And you need to do that for each hour of gardening. So if you're out in the garden for hours, you're going to have to reapply. So I like this. I think this is great. Now, signs and posters are isolated cues, and they might be a little far from the site of practicing the behavior. People might forget to practice a behavior by the time they arrive at the site. So there's something we call nudge interventions. They're comprehensive. They put multiple cues in place in a coordinated way, and behavioral economists call this choice architecture. And this isn't going to mean much to you, so I'm going to show you an example of nudges. So this concept originated in behavioral economics, and there was a book that got a lot of attention at the time when it came out called Nudge. And they said you need to redesign the architecture of choice to steer people towards specific choices or behaviors while still maintaining options for people. Now, for each behavior being promoted, you need to reinvent what we mean by nudge. So now I'm going to show you an example. This example comes from Bangladesh, and in this study, they were trying to promote hand washing with soap after going to the toilet. And they found that kids in schools weren't washing their hands after going to the toilet. And that was a problem because those kids could get diarrhea or even cholera. So they implemented a nudge intervention. And what is fascinating to me about this nudge intervention is they had no health education and no science classes. They didn't talk to the kids at all. The entire intervention was taking this environment. So in the left photo, you can see latrines or toilets on the left, and the right photo, you're looking head on at the latrines or the toilets. And they found that kids weren't washing their hands, even though they had a place with water. So what was the intervention? Here is the intervention. If you look at A on the left, you can see the doors of the toilets, and there are footsteps on the ground leading from the door of the toilet to the reservoir of water. And you can see hands are painted on that reservoir. And B on the right, again, you can see the doors of the toilets and footsteps along the ground leading to the reservoir with the water for hand washing. So, hand washing with soap among children was 4% at baseline, and it increased to 68% the day after the nudges were completed, and 74% at 2 weeks and 6 weeks post-intervention. So they had no explanation about bacteria and viruses. They didn't talk about diarrhea. They didn't talk about cholera. They did not talk to the kids at all. All they did is these nudges, which were intended to get the children from the toilets to the hand washing station and to get them to wash their hands. But they didn't talk to them. So What could a nudge intervention look like for a park, a trailhead, or a conservation area? Well, you could have arrows from the parking lot lead to a bench at the trailhead. Then at that bench, you could have a sign next to the bench that reminding people to apply repellent before starting a trail. At the end of the trail, you get an arrows pointing to another bench with a sign providing instructions on how to perform tick checks, what tick nymphs and adults look like, and the seasonal abundance of nymphs of the park. And finally, the icing on the cake would be this is where everyone does tick checks, because that's trying to influence descriptive social norms. So the arrows along the entire route and the signs all together, that's an example of choice architecture, trying to promote repellent use and tick checks at a park. So I was talking about I've just finished talking about the 3 factors that I consider to be highly influential. Now I'm going to talk about 2 that I consider to be slightly less influential. So a lot of behavior change interventions, they give people a ton of information about vector abundance, about biting. We talk to people about what all the different kinds of ticks are, what all the different kinds of mosquitoes are. We explain the seasonal changes in tick activity. So, by the way, I find this diagram extremely informative. It's very useful for me, but the literature shows that this kind of diagram doesn't change behavior that much. Because you have to look at this and you got to study it and you got to think about what does it mean for behavior. Like there's a lot of steps you need to go through in your mind to get to the behavior. One reason that this kind of thing doesn't seem to lead to behavior change that effectively is it's several steps away from the behavior. I just mentioned that. It's difficult to understand the implication of information about vectors. What is the implication for what to do, when to do it, and where to do it? So signs and nudges and other things are a lot more direct about that. And another huge problem we have right now in 2026 is competition with other sources of information. We have advertising for human and animal drugs and products. And then people have their own personal experiences with mosquitoes, with dog, cat, and human ticks, and seeing ticks on deer while hunting. So here's an example, all these products, and it kind of starts to confuse people. So, I think this information would have a much bigger effect on behavior if it weren't for all the other competing information, which is from both advertising and personal experience. And then perceived susceptibility and severity of vector-borne disease. We keep coming back to this in public health. We say, this disease is terrible, it's going to kill you. And so we could be telling people, look, there's all these diseases. There's Lyme disease, there's anaplasmosis, there's babesiosis, there's alpha-Gal syndrome, there's Rocky Mountain spotted fever, there's all this stuff. And then there's mosquito-borne diseases. There's West Nile fever, La Crosse encephalitis, Eastern equine encephalitis. But there's very little evidence that this has impact on behaviors. So Carpenter 2010 is an example of one study. And Carpenter was looking at the health belief model, which is a model that has disease severity and susceptibility in it, but also has benefits and barriers of practicing the behavior. And looking at a number of studies, this review didn't find that disease severity and susceptibility affected behavior. So you would think, knowing that the disease is serious and knowing that you might get it, that would change behavior, but it doesn't seem to. One reason that there's a long path from thinking about the disease to thinking about specific behaviors to protect from vectors. So people have a hard time translating information about the disease to the behaviors. And then people hear about so many diseases all the time. If you want, if you turn on a television feed for a while, about every 5 minutes they're talking about another disease. Half the disease you never heard about all the time. Like, there's so many diseases that are being talked about, it's hard for any disease to rise to the top. So this has been a whirlwind tour, a few conclusions. If you're promoting a behavior, you need to know what you're promoting, and it needs to be defined in a way that's specific. It needs to be modifiable. It needs to be feasible to practice a behavior, and it needs to be measurable. When we promote behavior change, we pick behaviors that we think are going to have a direct public health impact or will create the conditions for public health impact. Then we look at what factors affect those interventions and what can we do to change those factors. We in public health and vector control communities, we spend a lot of time explaining to people what are all the different vectors, what their seasonality is, where they bite, what the diseases are, how awful and terrible those diseases are. But the evidence in the literature across many different diseases is that the big three in changing behavior are social norms, self-efficacy, and cues to action. Social norms is important for all behavior change at all times. If you can convince people that other people are doing things, they'll do it. Self-efficacy is important, more important for some behaviors than others. It's very important for tick checks because tick checks are hard to do, and a lot of people lack the confidence to do a tick check. They don't think they're going to be able to find the tick. And then cues to action are very important for all vector-borne diseases because vector-borne diseases are focal. They're transmitted in specific places at specific times, and people need to be cued or reminded to do the right thing at the right time. So thank you. I'm done, and hope I have some time for questions.
Thank you so much, Peter. Yeah, we do have some time for questions. Let's see. I would like to share my screen really quickly. Just have to, of course, figure out how to do that all over again.
There's a lot to digest in little time. I mean, another thing thinking about the audience is there's so much variation in vector-borne diseases. You might have a very specific scenario, and you might be struggling to think, how does what everything Peter talked about apply to my very specific scenario? And I accept that. So should I be looking at the Q&A thing?
So yeah, so let's see. So we have one question in the Q&A. I'm gonna pull it up.
Okay.
Unless Olivia, you got to it first.
Okay, well, Ashley Knock has asked a
Two
question
questions.
that is...
I can read it for everyone if
Yeah,
anyone's
okay.
just listening. So Ashley had two questions. One is, do you have any input about discouraging preventative behaviors that may be undesirable for other reasons? For instance, a lot of new housing developments in Pennsylvania are full of deer, and I'm seeing more and more people have their yards sprayed by pest companies for ticks, but that's undesirable for numerous other reasons. I don't know if you want to get to that one, and then there is a second question after that.
Well, people are busy, and there's a lot to deal with all the time. It seems easier to get somebody to come, like, just look after the problem. Demonstrations are very important. And you can tell people things, but if they can see it with their own eyes. So for something like having a company come in to spray for ticks, like, if you could demonstrate that even after doing that, there are still a lot of ticks around, and it's going to be especially effective if you can have people talking from the area and say, you know, I had a company spray for ticks, but then here I can still see there are ticks here. In fact, look at my dog. I just pulled a tick off my dog, and this is like 3 days after paying that company. Or my 5-year-old, I just found a tick on my 5-year-old. Um, but just telling people doesn't work, isn't going to, you have to be able to demonstrate it. And I don't feel like I can go into more detail on that without knowing more about the situation. But one thing that can work against us is people can observe things like ticks on deer, ticks on dogs, and they may come to different conclusions from us. So a starting point is often, what have you observed? And we might give people different interpretations. Okay, sorry, that's a long time on that. Let's go to the next one.
Yeah, that's great. The next question, unless Ashley had any follow-up questions, but it doesn't.
Okay, well, the second one here is about balancing public health fears.
Yeah, okay, yeah.
Well, the literature shows that doing a fear-only approach doesn't work very well. And part of the reason is there's so many things that people are telling us to be afraid of all the time. Like, people just get overcome by it. You have to give people specific examples from their area, if at all possible. So people who are very outdoorsy, you'd say, yeah, it's good to enjoy the outdoors. But you know, here are some examples of some people who picked up one disease or another, and here's how they picked it up. And maybe if you can show them like where they picked it up, or have them talking directly, you know, that's going to have more impact. Hearing from the people who've experienced the thing rather than us, the experts, you know, that's more effective. But I don't think our primary goal should be proving that one thing or another is wrong. Our primary goal is positive in that we're trying to get people to do things. And the most effective way of getting people to do things is convincing people that others are doing it. So for outdoorsy types, convincing people that other outdoorsy types are taking this precaution, and that other outdoorsy types have not found the precaution to be too burdensome or too difficult. They were able to do it, and they were able to integrate it into their routines. So creating a social norm among the outdoorsy types, I think, would be the way to go. Okay, maybe we should get on to Joellen. In models, I have to see self-efficacy and confidence as separate factors. They seem similar. They do overlap. Self-efficacy is defined for specific behaviors, and it's like the confidence to be able to do every single step in the process. So, for example, self-efficacy for condom use in teenagers has become a lot more difficult now. And the reason is that condoms are now increasingly locked up at pharmacies. So condom use means going to a pharmacy, finding the condoms, asking somebody to unlock the cabinet, and then going up and paying for it, and then negotiating condom use at the time of sexual relations, and then using the condom. And you have to have self-confidence for each of those things. So self-efficacy is defined in a much more comprehensive and specific way than confidence. And in the case of condom use, you would have to have confidence to practice each of those behaviors along the whole trail. But there's a lot more. This is a quite an extensive area of literature. I could probably say more, but I'm running out of time. I see. Are there any other questions I haven't answered, Indira?
I don't think so. I'm gonna check the chat really quick. Yeah,
Well,
Ashley said,
people. Um, if you email me your questions, I'll also try to answer them. Um, and I know a lot of university faculty don't answer emails, but I perhaps I do answer emails. Actually, I find myself answering a lot of emails from people these days about how to get a job in public health because that has become very difficult right now. Okay, so there's my email address. But
yeah, and I'll also send
Ashley,
out,
Joellen, if you just send me your questions, I could give you a more complete answer, and I could also probably attach an article that talks about it.
yeah, so we will be sending out a, a list of resources after this webinar concludes, and I can include Peter's email address on that, and that will go to everyone. So I know we have only a couple minutes left, so I just wanted to go through a couple things, housekeeping before we leave. Reminder that this presentation is for educational purposes only, and you should always seek the advice of a licensed doctor or vet medicine official or professional if you have a question regarding a condition or symptom. We have an upcoming webinar in May, on May 14th, 2 p.m. Eastern Time. It's on focus groups and qualitative data, and so that will be really interesting. I know that I'm really excited for this. So this will introduce the fundamentals of facilitating, organizing, designing focus groups, and it'll give an overview of qualitative data analysis as well. So that should be exciting. You can you can access it via this link that's at the bottom of the screen. You can also, am I still sharing my screen?
You aren't sharing anything right now. You're going to need to share again.
Yeah, sorry about that. Yeah, you can access
Oh, yeah,
the
that's good. Thank you.
yeah, you can access next month's webinar at the link at the bottom of the screen or via the QR code. And then lastly, you can keep in touch with us at these links, which Olivia had already pasted in the chat. You can find past webinar recordings and other resources at our website, VectorEdNetwork.org. We have a newsletter that comes out every month, so you can sign up for that as well. If you have questions about this specific training and evaluation center, you can direct them to Erica Machtinger at Penn State. And lastly, I do have an evaluation for everyone to fill out if they have the time. You can access it at with this QR code at this link in the bottom, and I think Olivia will also paste it in the chat. That's just so that we can figure out how you guys liked the webinar and what we can do to improve future webinars and what topics we can cover in the future. And that is
Yeah.
all I
Thank you
have.
for attending and thank you for your questions. And feel free to send me questions.
Great. Thank you, everyone.
Okay, Olivia in Philadelphia, Indira in Lancaster. This is goodbye from Peter in Baltimore, and goodbye to all of our attendees.
Wonderful. Thank you so much.
Thank you, Peter. Thank you, everyone.
Yeah,
Have
bye.
a good day.